Okay, thank you all for being back here on time. Can everybody hear me? No? Yeah, is it on? Now it is on. Okay, there you go. So I was saying thank you all for coming back on time. I'm very excited to open the next session with who I would call a true global citizen. I think Naor is not only the WHO unit head for immunization analysis and insights, I love that, that's pretty awesome, but also the deputy director of international vaccine access, if that's still correct. But Naor is one of the very few people that I thought the song from Sade, for those of you who may remember, The Smooth Operator, speaks 7 languages, and I think, Naor, you have roots in all cultures, in all continents, both professionally and personally. So you really are a true global citizen, and it's an absolute honor to have you give us the keynote lecture for today. Thank you.
Thanks. Great. So no sorry, I'm hearing echoes. Can you hear me okay? A bit loud, no? It's okay? Okay, great. All right, so I don't have any slides. I just want to start by thanking you all for inviting me. I want to thank Peter, Christine for driving this field, for your hospitality as well, and I want to thank my teachers, Professor Shan and Professor Buttery, for you were there formal years of my training. So I want to speak frankly and directly. I'm not a specialist in the field of heterologous effects. More correctly, I'm a failed specialist, I think I would say. So long ago, I submitted a Wellcome Fellowship, after that an R01 grant in this area, hoping to progress the science, and I failed. Actually, in the review, the methods were celebrated, they were lauded, but the fundamental question was seen as not important, right? So I bear a bit of a grudge about that. But I've reinvented myself as a health bureaucrat, or, with a bit of a flourish, you could say health diplomat. But I remain a middling, mediocre, and now middle-aged academic researcher as well. I'm a practicing pediatric infectious disease physician, recently returned to practice, which was fun for a while. I'm a statistician and a vaccine epidemiologist, and I head the immunization data and decision-making unit at the WHO. And I remain a cautious champion of this field, both within the WHO and without. So I'm here formally representing the WHO, but I'm also here among friends. Some of you are old friends. Well, the friendship is old, you're not old. And so I want to position myself and the WHO and yourselves in a sort of a triangle so that we can have a bit more degree of freedom, perhaps. I want to briefly address the challenges that face us as a broad immunisation community. I want to contextualise in that the tension, I think, that's existed between this field, the heterologous effects community, and the WHO, and I want to try to seek a way forward. And I think we can all make the presumptions that vaccines are important, that they're broadly safe, and that's not the content of our address. I want to briefly reflect on scientific paradigms. We already heard from Professor Poland the mention of the scientific revolutions, which I'll refer to in a second. But I want to start with a story that you probably all know, which is the story of Ignaz Semmelweis. Ignaz Semmelweis was a Hungarian physician. At the end of his life, he was relegated to the madhouse by his peers. And the story, of course, is that he observed that puerperal sepsis occurred less commonly among the midwives who washed their hands in chlorinated lime solution than among the medical doctors. And he postulated that puerperal sepsis was transmitted on the hands of the doctors, perhaps even by an infectious agent, which is, of course, a preposterous notion. And so his sad ending is well known. I would say that perhaps since the decline of prophecy, the idea of truth resides with children and with fools, and perhaps it's really the other way around, that when you speak truth to a paradigm, then that sort of defines you as a madman. So I recognise that that's been the case. But when we consider the changing in the scientific paradigms that was mentioned the other day regarding Thomas Kuhn's structure of scientific revolution, I have to say it's been now a frighteningly long time ago since I read that work. But the residual impression that it left with me is this kind of sense that you have all of this evidence building up, and it's resisted, and then suddenly the waters break and out comes this new paradigm like a birth or something like that. But I want to argue that that's not the case. Okay, there wasn't a Copernican moment when suddenly we realized that the Earth isn't in the center of the solar system. It took a long time. Okay, we knew that we were heliocentric, but we didn't really fully understand the meaning of what it means to be geoeccentric or even homoeccentric, right? That we're not at the middle of things. We don't have the absolute vantage. Perhaps we don't have the absolute at all. Okay, that took a long time, and it wasn't something that was... The consequences of the scientific facts didn't percolate fully until quite a long time after, and I think that can be demonstrated in other episodes in the history of science. So, there are a lot of claims that are made in science, and some of them are methodologically rigorous, but we don't always listen to the facts such as they are. In my own tradition, there's this legend or a belief that when you chop down a tree, it gives out a cry that stretches from one end of the world to the other. But nobody can hear it because everybody's too busy making their own noise. Right? So sometimes there are things that are obvious, but we don't take them on board. Okay, so that's a little bit of a reflection on scientific paradigms and the expectations around them. But let me quickly talk about the situation that we're in at the moment in terms of immunization. Measles is a tracer for immunization system performance because of its high infectivity. We see it rise soon as so-called canary in the coal mine. There was a book written by Émile Zola called Germinal, which was about the coal miners in France 150 years ago or so. And in it there's a horse called Trompette, and she gives birth to a foal, Bataille. And Bataille carries the coal underground, and he spends his entire life underground. Eventually, in the novel, he dies. The horse dies underground. The horse is born and lives and dies underground. Right? And so it's a strong leitmotif in the novel to sort of reflect the burden of unfair work on the coal miners. But the situation that we're in now is not the canary in the coal mine. It's the pit pony in the coal mine. It's the horse in the coal mine is dying, not the canary. We're having huge diphtheria outbreaks across the world, even in the European region, in Australia, and certainly in the African region. We've got large, can't really call them outbreaks, but many cases of tetanus in adolescent boys with open fractures, for example, being reported from Conakry. So there are things that are deeply wrong at the moment in health systems and in vaccination systems. We're rapidly returning to measles endemicity. We're losing hard-fought and hard-won gains. The number of zero-dose children in the world are increasing, not decreasing. There's more heterogeneity than before. Let's call it inequality, if you like. The dropout rates in low-income settings remain 1 in 5. So even if I get kids in to get their BCG or their DTP, they're still 1 in 5 of those kids aren't going to get a measles vaccine. And measles case fatality, despite global modelling that shows an expansion of measles incidence and a reduction in measles overall mortality, that's just a function of modelling. That's just a function of the assumption that in high-income settings where we're now seeing measles, that case fatality is 1 in 3,000 or whatever. But recent case series from Israel and also from Mexico and from Canada in special populations, subpopulations, we're seeing fatality of 1 in 200. So we're seeing measles resurgence. And a lot of that death is from concurrent bacterial sepsis, cases of measles, and sometimes they're not counted because they're occurring some weeks after measles. You have a kid who had measles, and then they come in with group A strep sepsis and they die. That doesn't even get counted. So, the world officially remains committed to measles elimination, and in global meetings you hear opinions floated that perhaps it's a bit too soon to aim for eradication, but in the real world, like, measles is just on fire everywhere, right? We're completely disconnected. In the policy world a little bit, and in the health advocacy world from the reality that we're facing. Yes, there's a role for demographics, and in Africa there's an increased birth cohort. Africa has to vaccinate more children every year just to keep coverage the same, but they're doing that, and Africa is the only continent that's returned to the pre-pandemic baseline, at least on last year's analysis. It might change. In the meantime, in Montenegro, measles coverage is less than 50% in the heart of Europe. I think we can still call it the heart of Europe, right? Half of the world's zero-dose children live in conflict-affected settings, and that's not a very precisely defined metric, but nevertheless, and about 1 in 4 children in settings that are vulnerable or conflict-affected is unvaccinated. We're seeing outbreaks of CVDPV in OPV using countries, and the degree of CVDPV is a function of IPV coverage. Okay, so if the system is working, then we're not seeing outbreaks from OPV. But if the system is weak, then we're seeing OPV-associated outbreaks, and there's a delicate balance to be had, I would argue, on those issues. Measles outbreaks also occur on the basis of low routine coverage, right? Lots of countries do campaigns that help reach 95%. You can jump and whatever, but you're not going to reach 95% unless you're starting at a high baseline. So routine immunization systems need to function, and they're increasingly becoming dysfunctional. And the reason for that is the global health architecture is in flux. There are funding cuts, as we've heard. I would say that maybe in the long term those funding cuts are needed. We want countries to stand on their own 2 feet, as it were, but the way it's happened is really quite brutal. Domestic expenditure is needed, but there are now other competing priorities, defence and other things that are pressing and genuine concerns that compete for the limited dollar. At policy level, vaccine schedules are now full, they're replete. We've got lots of new antigens that have come on. And so there are more introductions, and those introductions will save lives. RSV vaccine, novel TB vaccines around the corner, dengue vaccine, but they require a trade-off at local level between a limited number of health workers, limited number of dollars, limited facilities, and so on. So how do we make those trade-offs? How do we optimize our investments, and how do we optimize the schedule itself? I think there's a big opportunity for this conversation to feed into that. Post-pandemic, there was a so-called big catch-up program, a massive investment in countries to help catch up kids who were missed during the pandemic. Among those countries, about half improved routine service delivery and about half didn't, right? So just because you give a vertical injection of money doesn't mean you're fixing endemic problems. Sometimes it helps, but not always. We need to understand those systems holistically. Okay. And of course, as we've already heard in this meeting, but you all know that we're at a time of polarization and societal-wide loss of discourse, critical thinking being replaced by groupthink, and I would argue, although we've heard it several times in this meeting, but I would argue that it's all too easy to frame others' views as illegitimate or misinformation. I think that's a dangerous word. There's a loss of confidence in all of us, not just in vaccines, but in science itself, and in scientists, and certainly in government. And that's not only among the public, but it's also within the scientific community itself. Where people are heavily relying on models, and models have their place, but as we know from George Box, they're all wrong, but some are useful, okay? So I think we need to bear that in mind. Science used to wear the crown of skepticism, and now science is to be believed, which we've heard that also during the meeting. And some of the catechisms of the new faith can be quite disturbing. I worry that advocacy, for good reasons, is replacing prudence and caution. So that's the environment that we're in. And in terms of the markets, the future of the vaccine market remains uncertain and unstable. There are a few companies that make a limited number of antigens but make most of the money, and there are another group of companies that make most of the product and a little bit of the money, and they're quite distinct, and that's not a sustainable thing. And there's a push towards regional manufacturing, which is sort of, I understand where it's coming from. It's trying to right historical wrongs, etc., etc. But that fragmentation of the market also potentially reduces the stability of planned expenditure for stable long-term manufacturers. And the government investment in those large manufacturers is also unstable. So we may end up losing out from both sides, right? Okay, so what about the WHO? Sounds very negative, my talk, okay? It's the reality, I think. So like many institutions, WHO has taken a big blow. Immunization, vaccines and biologicals, which is my department, has lost 40% of its staff in the last 6 months and half of its activity funding. This change is going to be permanent. It's not going to change at the next US election or anything like that, and it may not be the end of it. There may be more cuts. Regional offices are struggling, country offices are struggling big time. Really, a few quality people have to carry a lot on their shoulders, and their shoulders are no wider than they were before. And activities are being rationalised and prioritised. Dovetailing among the different global partners, UNICEF and Gavi, etc., is more needed than ever. And there's some tension internally, I think, between HQ, between headquarters' normative and standard setting role and policy role, and its ability to provide country support and technical assistance. I think there's a tension where we really need to put our emphasis. And we've lost a lot of depth, a lot of corporate knowledge, a lot of just scientific knowledge. We've lost excellent people. And although there are excellent people that remain, but as I say, their shoulders are no wider than they were before. In terms of assessed contributions, which are what countries pay to the WHO, IVB historically has received very little assessed contribution because we've generally been able to raise our own money, but that's no longer the case. And unless assessed contributions from countries rise and are focused on this area, it's going to be a major problem. So I just want to add one other thing about WHO structural change, which we're undergoing. So there are several technical divisions at WHO. There's sort of the core WHO. Then there's the Health Emergencies Program, sometimes referred to as WHE. They deal with Ebola and pandemic potential. And then there's also the Science Division. And there are, beyond that sort of division, there's also the three-level division of HQ, regions and countries and so on. And things move lugubriously slowly at the WHO. Historically, a statistician might call it an autoregressive way, so things tend to be the way they always were. But it is changing, or at least there's a real attempt to have it change. But why is that relevant? Well, in the past, some of the reviews that occurred of the methodology of non-specific effects, including by some that I submitted when I wasn't in WHO, were managed in the Science Division and were managed by let's say institutions are not just structures, they're also individuals and they are idiosyncrasies. And I'll suffice to say perhaps that some of those idiosyncrasies are no longer at play. Okay, so I think there are opportunities now for an openness towards this field that perhaps we didn't find in the past. I would even go as far as to perhaps to say that historically there's been some intransigence to this area. But that's really not the case. I just want to reassure you that there really is openness to the policy implications of vaccine non-specific effects. Obviously, we have to be absolutely rigorous in any policy-facing science. It's not to say that there can't be hypothesis-generating work, or there can't be exploratory work, or there can't be a million different really very interesting omics, and you want to move the science for science's sake. But anything that is policy-facing has to be top-notch in terms of its rigor and its implementational relevance. And I would say that vaccine non-specific effects was slated to be on the schedule for SAGE in 24-25, and because of the whole disaster of funding and blah, 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 it's basically just we've just done the very basics to survive and get through other key policy questions. But there is an eye to this area, and there's an interest, an interest in this area. Again, we recognize that countries have to make decisions and choices, and they want to make the optimal choice, and that optimal choice needs to be holistic and needs to be schedule-wide. Okay? But we also know that at least in some settings where the context of mortality has declined historically, okay, there will probably be a rise, but we want to understand the relevance of findings from high mortality settings to now middle and lower mortality settings. The number needed to treat, which was shown before, is a critical thing, and obviously from absolute risk reductions from which that's derived also come cost-benefit analysis and cost-effectiveness analyses and all of these decision-supporting things. I do want to acknowledge the tense dynamic that arose recently in the context of planned clinical trials, as I mentioned already. I have to admit personally I'm not fully up to speed with where things now stand. But I really regret the polarization that this whole affair exacerbated. I think it can be overcome. I just want to acknowledge and to compliment people in this audience who maintained their composure, their professionalism, their consistency, their dignity, their poise, their collegiality under what must have seemed like very harsh personal attack from the very top of my institution. That dignity was not unnoticed by me, and I'm sure by many others. Words have unintended consequences. Sometimes over the long term. But I would also say that that's true all around. And injudicious use of words, even in past papers or in editorials or even on the side, or perhaps some insufficiently careful post-hoc subgroup analyses that can nowadays get picked up rapidly by trawling, actors with that can have consequences that are harmful to all of us, but more importantly harmful to children around the world. So the risk of vaccines must be framed in context of their benefit, and that context around vaccine confidence is rapidly degenerating. So we all want to understand better the immunology of vaccines. We want to understand their full measure of vaccines, for better or worse, in sickness and in health. And I think we need to do that together. So here's a suggested pathway. Maybe just recapitulate and be explicit, okay? Vaccine non-specific effects occur. It's accepted. It's not a question. Nobody would deny this any longer, and you are not Ignaz Semmelweis, okay? But if the expectation is that once accepted, once the paradigm is accepted, that everything rapidly changes, then to that I say we need to be realistic, but we also need to be smart, okay? Mechanistic knowledge is crucial, but it doesn't define policy. The specificity versus systems thinking, it's important, but markets and governments have pragmatic considerations, and they are making fiscal and ethical trade-offs that are serious and have gravitas. They shouldn't be dismissed as population is simple and immunology is complex. No, systems thinking isn't restricted to the unfathomable complexity of the individual. It applies also to the unfathomable complexity of societies and of the world, and we need to think in systems thinking and in reductionist thinking where appropriate. We need to use the right tools of cognition as appropriate to our questions. Epidemiology and population health are also very complex. So, I'm coming towards the end. People want to do the right thing, okay, all of us, but being human, sometimes human beings are frail, or they're defensive, or they're uncertain, or they feel under attack from one direction, and so they become defensive in other directions. But none of us are madmen, okay? But there are real madmen out there, and I'm not pointing to any particular politician. No, really I'm not. I'm genuinely not. I probably have different political views to many of you. And there is a lot of other evil that is at our gates, genuinely, and we have to protect against those forces together. Okay, so the question isn't anymore if non-specific effects occur. The question is, in what way are they relevant, and how can they be harnessed and appropriately used? How can they be pragmatically harnessed? In what context, using what decision processes, and using, forgive me for this corporate talk, but what change management that's needed, okay? And what are the risks? For example, if we're seeing re-emergent old foes, like CVDPV or polio, we need vaccines' direct effects. We need those. So does the benefit of OPV outweigh the harm of CVDPVs, for example? And in what context? And in what way? And under what circumstance? What is the absolute, and not just the relative risk, of DTP in girls? I mean, of diphtheria or tetanus or pertussis in girls, and how does that trade off against potential harms of vaccine and so on? I would remind you also that the emergence of diphtheria isn't an acute thing. It's not you drop your vaccine rates and along comes diphtheria. Diphtheria is a decades-long change in lysogenic conversion and ecological competition among toxin-bearing strains and so on. So being at the super advanced vaccines 5.0, 6.0 generation of vaccines is all fine and good, but we never really finished with vaccines 1.0. We need to get vaccines delivered to children where they need them. Funding for operational change needs evidence to be channeled through the formal processes of policy making, and it's no longer sufficient just to be in the arena of peer-reviewed science. So our research has to ask the relevant policy questions. We also have to know when is the evidence sufficient to make decisions, and there'll be arguments about where that point is, and that's okay. But research and argument shouldn't impede moving forward on important vaccine decisions. We should be better as a community at putting forward the right questions and then define and agree a priori on the rigorous methods that are required to answer them. We need to support the conduct of the right studies in the right context. We heard some of them today. Brilliant work. Where it helps, we can use modelling, especially to guesstimate or estimate absolute risk reduction, in other words, local impact and cost benefit, based on empirically observed relative reductions. But a 50% reduction in somewhere doesn't mean a 50% reduction somewhere else, okay? And certainly doesn't mean the same absolute risk reduction. So that's important to take that in mind. We should review the collective bodies of evidence and agree openly, explicitly, and in advance on the methodology to do so. And that's true just as much for the WHO, right? If we're going to be commissioning a systematic review, and then after that, an external person comes in and says, well, that systematic review just isn't good enough because you didn't consider the effect of the subsequent DTP, the whole thing becomes useless. So we need to get views that disagree with us to do the best science that we can do. Okay, so we should return to centre. We can agree to disagree on some things, no problem, but we need to work together on other things. We need to be mindful of the negative forces that we're all facing, and we need to be honest and open, but careful in our phrasing. And yes, we owe it to the public to be warts and all of that, that's true, but we need to do it contextually, sensitively. We need to be mindful of how words will be interpreted and used by others. We remain in flux at the WHO in terms of our funding and what we can even do, but we are keen to progress much of what has been discussed in this meeting. We would welcome joint discussion on how that can be achieved. It needs to be anchored around processes for SAGE. Okay, that's how policy will get made. And solid preparation for that, which takes a long time and a lot of work, is well worth the effort, notwithstanding this sense of urgency that look at the evidence and we need to act on it. Okay, going back a little bit to the philosophy of science, I spoke about the history of science. The formalism of science, its method, Karl Popper reminds us, is the way that we solve our questions. But I want to say that it's not necessarily the way we pose those questions. The questions that we ask arise as a function of our all too human interest. And by interest, I'm invoking all the senses of that word. Interest in terms of curiosity, interest as in the stakes that we hold, including ethical stakes, and even interest in the physical sense, because there's lots of money to be made and profit to be made from some of the science. But Popper also tells us that falsifiability and profound skepticism are the hallmarks that distinguish science from metaphysics. And exceptional science is inherently non-dogmatic, non-ideological, uncommitted, or maybe you could say committed to the non-knowing, to the ineffable, unreachable absolute. Scientific truth is best served when we're skeptical, but most of all when we're skeptical about our own hypotheses. So I'd like there to be peace, but not necessarily harmony among diverging views. Truth is tolerant of her exploring little children that we are, but she does expect us to act impeccably, impactfully, and I want us to do that together. So that's the end of my comments. Thank you.